Assalamu alaikum. The short clinical day. First scenario, Mrs. Sophia, 26 years old lady, present with abdominal discomfort. Please examine the patient's abdomen. Okay, ready?
Okay.
Here you go.
Okay. Okay. Hello.
Hi, hello. Hello.
Yes. I am Dr. Ahmed. I'm doctor in the clinic today.
Hi, Dr.
Um, Hello.
Hi, Dr. Ahmed. Hi.
Yes, today we are here to help you and examine you. Is it okay with you?
Yes.
Okay. Um, can I confirm your name and age, please?
I'm Sophie. I'm 26 years old.
Okay. Do you feel any pain now?
Not at the moment, no.
Okay. I will examine you. If you feel any pain or discomfort, please let me. During my examination, then inshallah I will stop.
No problem.
Okay. I will see for surrounding.
Nothing on the
Is there
surrounding.
any medication, glucometer, anything? Nothing.
No.
Okay. Then I will sit at the end of the bed. I will ask the patient to expose first or
Okay.
abdomen. Then I
Okay.
will. Can you give me cough?
Uh, uh, Cough is normal. Can we share the photo, Dr. Bassem? I'll try to share it. Yes.
Yes, it's shared already.
Okay. Are you able to see the photo, Dr. Salma?
Yes, yes, I can see now. Okay. Um, okay. Can you take deep breath in and out?
In and out is okay.
Okay. I will examine hand
Okay.
for any clubbing,
No clapping.
any clonicia, lyconicia,
No.
any palmar edema,
No.
any doctrine contraction.
No.
Then I will examine also for fine tremor. I will ask the patient to spread your finger.
Normal.
Okay. I will examine also for flapping tremor.
Normal.
Okay. I will examine pulse.
Pulse is regular.
Okay. Um, then I will check blood pressure.
Normal reading.
Okay. I will ask the patient to pull eye to check for pallor.
Normal. No pallor noted.
No, no jaundice.
No jaundice.
Okay. Then I will examine mouth
Okay.
for any oral ulcer. Any uh,
Normal.
okay. Any candidiasis.
Normal.
Any gingival hypertrophy.
No gingival hypertrophy noted.
Okay. Then I will examine neck. I will tell the patient, can you tilt to left by head? I will check for GVP.
JVP is normal.
Okay. Then I will press abdomen. I will ask first, is there any pain in the right upper quadrant? I will check for hepatojugular reflex.
Normal.
Okay. Then I will examine a lymph node, cervical lymph node.
Cervical is normal.
Okay. Any other group lymph node enlarged? Neck?
In the neck, no
Yes.
lymphadenopathy.
Okay. Uh, as the patient sitting, I will check also for sacral edema
No
or
sacral
any
edema.
basal crepitation. Okay, thank you. Then I will make the bed flat to examine the abdomen. Superficial firstly inspection for any dilated vein, um, for any mass, for
Normal.
any scar. Yes, I can see now
Scars, you
like
can see them. You can see the scars.
yes, I see now like collagen block. Okay, okay. Then
Are you able to see anything else?
um, I see there is back.
Yes.
Yes. Then I see, yes, I can see also a small scar, maybe for previous surgery.
Okay.
Okay. Then I will examine the bag for content of the bag. Is it
Mm-hmm.
solid? Is it liquid?
Semi-liquid.
Okay. I will examine around the stomach for any ulceration, any skin changes
No ulceration.
1 minute
around the neck
left.
of this bag.
Hmm?
Okay, superficial palpation.
No tenderness.
Okay, deep palpation for liver,
No
spleen.
organomegaly.
I will check liver span, and also I will check spleen, how many centimeter
Mm-hmm.
span. Normal. Okay, I will
Normal.
do palatable for kidney.
No palatable kidney.
I will do shifting dullness for ascites.
No shifting dullness.
I will auscultate abdomen.
Okay. Normal.
Okay. Then,
You
then
where you
I
are
will do
auscultating?
I will auscultate for any venous hum, for bowel sound also, and
Mm-hmm.
for any, yes, any brood.
No. No puree
Oh,
bowel sound are normal.
okay. Then I will examine lower limb for any lower limb edema.
No lower limb edema.
Okay, time's up.
Okay. I will
Time's
thank
up.
I will thank the patient. I will cover the patient.
Perfect.
Thank you.
Yeah, examiner questions.
So can you summarize your finding in this case, please?
Um, I have examined. This is a gentleman. Um, uh, by inspection, um, there is nothing in the surrounding. There is a colostomy. There is ileostomy back. There is
Mm-hmm.
back in the right upper in the right side of the abdomen,
Mm-hmm.
with the semi solid content, most likely ileostomy back.
Mm-hmm.
Otherwise, normal examination apart from uh,
Any other findings?
no organomegaly. There is a scar, indication of previous surgery.
How many scars?
Uh, 4, 5.
Okay.
There is one big scar and there is a small scar,
Where is the
maybe
big scar?
for laparoscopic.
Mm-hmm.
Um, 4, I think, up 4 scar and one in the lower abdomen, one big scar.
Where is in the lower abdomen?
Uh, in the left iliac fossa, down in the suprapubic area.
Okay. So
Okay, in right lower
what
quadrant.
okay. What do you think this patient might be having? Or what's your
Uh,
differential for having ileostomy, basically?
Ileostomy is the most likely to be inflammatory bowel disease treated by surgery, by this done ileostomy. And
Okay.
most likely, this ileostomy in the right side. So my first differential in inflammatory bowel disease may be Crohn's disease, then ulcerative colitis.
So Crohn's is the first diagnostic, is your first differential, then ulcerative
Yes,
colitis. Is that correct?
yes, my first diagnosis is Crohn's disease.
Mm-hmm.
Yes,
Okay.
yes. You mean okay?
N n
Other
Any possible differentials?
um, other differential. Uh, Other differential may be like maybe celiac disease, maybe gastroenteritis, um,
Mm-hmm.
maybe
Mm-hmm.
bowel cancer,
Mm-hmm. Okay.
maybe
Uh,
irritable
how
bowel syndrome.
how you would like to investigate this lady? This lady.
Apart from general investigation, full blood count, renal function, liver function, and inflammatory marker, I
Mm-hmm.
will do calprotectin
Mm-hmm.
and uh, also uh, I will do abdominal ultrasound
Okay.
and CT if needed, and also chest X-ray for abdominal X-ray, sorry,
Mm-hmm.
for to check bowel if there is any obstruction or dilated colon.
Okay. How did you know how you can differentiate between ileostomy and colostomy?
Ileostomy will be in the right side of the abdomen
Mm-hmm.
and will be semi-solid content. Colostomy will be in the left side of the abdomen and will be solid content.
Okay. Any other signs you would know from seeing the stoma
Yes,
itself?
in ileostomy, there will be neck in the back
Mm-hmm.
will be not directly attached to skin. There will be
Yeah.
neck, then back.
Okay. Do you know why they are it would be fashioned this way? Like they are why they
I
are
think
making. Mhm.
because the content of
Mm.
the abdomen can cause irritation
Mm-hmm.
around the area.
Do you want to revise your differential then? You think
Uh,
this lady has Crohn's disease
yes,
is the most likely.
yes.
Okay. So in Crohn's disease, what type of bowel it is resected?
Mm, uh, small bowel.
Okay. And when you need to have ileostomy,
When
when you need to have an ileostomy, basically.
uh, when there is obstruction or failure of medical treatment.
No, no, I'm talking about, yeah, okay. So ileostomy is basically the, um, hello?
Yes, yes.
Okay. Ileostomy is connecting the small bowel to the skin. Therefore, we need to make a spout to prevent the content because we have taken out the large bowel. Is that um, uh, um, is that uh, what you meant? So since we are taking out the large bowel and we made an ileostomy on the right side, is that commonly done for Crohn's disease or ulcerative colitis?
Uh, only if there is complication.
Okay, thank you.
Yes.
Okay, thank you,
Thank you.
Dr. Omar. Thank you, Dr. Selma. You can comment now, Dr. Omar, the chat box containing the skills.
Uh, okay, just let me revise. Mm, physical examination, identifying finding, clinical judgment. Uh, so for the physical examination,
Yes.
she went logical. She took a while till she started to examine the check for organomegaly. Um, she managed to cover this here online because she just verbalizing, but this would affect her um, uh, um, in the real exam, to be honest. So I will give borderline for timing in the examination. But this is might not be realistic because she has tried to explain everything in the previous steps. identifying findings, I will give. So in the physical examination, I'll give borderline, and in identifying finding, satisfactory. Clinical judgment, I'll give borderline. I'll explain why. In differential diagnosis, she gave a sensible differential diagnosis. Satisfactory, she maintained the patient welfare. For the ileostomy is most likely linked with ulcerative colitis, not with Crohn's disease. Okay. So because in ulcerative colitis, the colon is usually be taken out, total or subtotal. So you need to have a connection. Either temporary ileostomy with and then ileoanal pouch, maintain the continuity and avoid the ileostomy, or to make an ileostomy with temporary mucus fistula at the time of the removal. The very big scar on the left iliac fossa, um, near to the left inguinal side, is representing the mucus fistula, which is temporary. What this indicates? This indicates that this procedure has happened secondary to a flare that wasn't responding to the medical treatment. So she had an emergency surgery. Okay? The numbers of the scars should be identified correctly. 1, 2, 3, 4 scars, and the fifth, 1, 2, 3, 4, and the fifth is the uh, left iliac fossa scar. She identified that this is an ileostomy, so that's okay. In terms of the differential, she gave a sensible, although she didn't prioritize the ulcerative colitis first. This would make the clinical judgment affected, but the differential, she covered most of the possible differentials for ileostomy in a young lady. I know that she might be, um, it could sound a little bit confusing if I'm speaking and she's a lady, but she addressed her presentation that I've examined this gentleman, which is, the confusion might be because that I am speaking, and sometimes this happens.
Yes, thank you, Dr. Omar. But I would like to give her in the physical examination satisfactory.
Okay.
However, yeah, for the online, maybe there is some barrier. So you can put it as borderline because she should be more fluent and fast in the exam. But she didn't miss any of the
No,
examinations.
no, 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 no,
She
she
didn't miss.
didn't.
Yeah,
No.
yeah. But you're right. In the on the face to face will be little bit slow, so she will have a lot of steps to do. And I agree. She started the real examination after minute one. She prepared. She asked. She stand and she checked the surrounding. But in the exam, you have to be very fluent and fast. No time to waste. No even seconds to waste. Otherwise, you might minus. You might miss a lot of finding. Anyway, the steps was perfect. The identify the finding also was perfect. She picked up all of them. The clinical judgment, yeah, you said you minus here in the clinical judgment for the point of ulcerative colitis. You mean?
Mm-hmm.
Okay.
Yes.
Uh, in order also to be logic, both of them are indication. The ileostomy are indication
For
for
ileostomy.
both. Ileostomy, yeah,
Okay.
it can be here or there. You sometimes you have also appendicular mass. You can have fistulae. You can do the ileostomy because the most common site to be injured or to be diseased or inflamed in the
Mm-hmm.
Crohn's will be the
Mm-hmm.
ileum, right? The terminal ileum.
Yes.
So you might have also obstruction there, you might have fistula. So it's okay to mention both of them, or you can say the ulcer occurs in if case the patient had also colectomy, total or subtotal, as you mentioned. So both of them you can prioritize,
Yeah.
but the cancer colon or any cancer can also be a differential, okay,
Yes.
bowel
Which
cancer.
she mentioned, yeah. She
She
mentioned
mentioned,
about it.
but
Yeah.
I disagree about irritable bowel syndrome. It's
I
Yes,
didn't
difficult to
yes,
I
say.
yes.
didn't
Yeah,
hear
so
irritable
She
bowel. I
yes,
she
missed
said
that.
it at the
Oh,
end.
okay. Okay, I missed I missed it.
The
yes,
last
yes.
differential she
Sorry.
mentioned, she said irritable bowel. Take care, don't mention it at all. Okay.
Yes,
Or you can clarify for the discomfort, but she the bowel is taken out, so I disagree with this also with
Yeah,
Dr.
yeah,
Bass.
yeah. This is also in the differential, but other differential was perfect and sensible, as you said. So the welfare also was maintained all over. She covered the patient. She thanked. She prepared. She gave instruction well. I think also that the discussion was perfect regarding the inflammatory markers you have to mention, because the flare up will be always associated with high inflammatory markers, leukocytosis. Of course, you
W-
have to say, I would like to take history also. Yes, Dr.
Yeah. One question I would like to ask Dr. Salma
Yeah,
about, because I don't think the time would fit only for one or two questions or three
yeah.
questions logically.
Mhm.
Dr. Salma, if this patient comes with high stoma output, how you will proceed?
present with
High stoma output.
high stomach output. I will evaluate for severity
Mm-hmm.
because this look like more frequency of diarrhea. That means
Yes,
Okay.
determines the severity of the disease.
yes.
Okay. So how you would
Inflammatory
complete
marker.
no things you should mention in completing your examination. You've done the examination. We don't do this in the exam, but we have to mention that,
Yes,
which
I
you've
will
missed.
complete my examination by examining the rectal examination, inguinal hernia, and
Mm-hmm.
um,
Mm-hmm. So in the rectal examination, what you are looking for?
for any mass
Okay. And if you
to
want, okay, continue.
I will examine for any mass because to exclude cancer. يعني
The,
I
the
will
examiner
examine firstly
question,
for mass, the rectal examination for mass for bleeding if there is any bleeding.
yes, but the examiner's question is if the patient comes with high stoma output,
Yes,
so there is no
Can she
blood.
define first the definition or the meaning of high fistula output or stoma
Mhm.
output? What we mean by it? How many for how long? Dr. Selma, this question for you.
yes.
When you can say this is high output or high fistula or high ileostomy output?
Mm, um, I mean uh, more production.
Yes,
How?
يعني
give me. Yeah.
producing more liquid stool.
Yeah, it's not by more or few or less. Yeah, of course
You
it's
mean
more.
number?
Yes, it's amount.
Maybe more than 2 liter.
It's 1.5.
Hello?
Yes, we can hear you,
Yeah, yeah,
Dr.
1.5
Maybe.
liters per day. 1.5
Mm-hmm.
liters.
Okay,
Okay.
okay.
Yeah.
Okay.
Now,
And
Mm-hmm.
now the
patient will be
complication.
dehydrated also with
Exactly.
electrolyte
This
loss
is what
like
Dr.
this.
Omar wants you to mention. So
Okay.
tell him about the complication. What complication you are looking for?
Okay. Will be dehydrated with electrolyte loss like sodium,
Perfect.
potassium.
Yeah.
But you didn't mention digital stomal examination. You don't only do digital rectal because the stoma, what you will find in the rectum is dead is dead pouch. Yes, you will do digital rectal examination to rule out any blood, any masses, but what's important is digital stomal examination. You want to uh,
I mention
as
it
same
like I
as
will see the neck of the stoma, and I will see
no
surrounding of the stoma,
no
or
digital.
any.
No, you will put your finger in the stoma. I know this is not our job, but this is what they wanted to hear. It's the surgeon. You usually
Okay.
call the surgeon would take care of the stoma. Okay, but in the exam, the
What called this test?
digital stoma, like you are doing
Digital
digital
stoma.
rectal examination. So it's the same.
Okay. I mean I pipette by my finger to stoma.
Yes, yes.
Okay. Okay. And
Yeah.
then will be for what?
So
For
it's to look for any stool changes, any blood in the stool, and blah blah blah. The same.
okay, okay, okay. Same like rectum. Okay,
Okay.
okay, okay,
So it is not limited to digital rectal examination.
okay.
Because once you verbalize digital rectal examination, one psychotic questions will be asked what you are looking for in digital rectal examination.
Okay.
So you will mention mass. If you try to say, I will look in any blood in the stool or blood staining, yes, but he had a different way of making stool right now, a different
Okay.
route, let's say.
Yes, plus the signs of dehydration, as you
Yeah.
mentioned, and in the
Dry mouth,
investigation,
dry.
yeah, all the signs of dehydration, and the investigation always look for the electrolyte disturbance and ABG. Okay, what do you think the ABG
Okay.
will be? The acid base. What's supposed to be?
Uh, acidosis.
Sure.
Not sure.
What the patient is losing through the stone.
What?
Is he losing acid through the stoma or is he losing bicarb?
Bicarb.
S- Okay. But
Okay.
Yeah, yeah. If losing bicarb means acidosis, right?
mhm, yeah,
Yes. Suppose if you are losing bicarb, so you will have acidosis. Okay.
yeah.
Any other question you want to add regarding
No,
the stoma output?
no. If you have any questions to add to this, Dr. Basim, you can ask
No, no. She mentioned
both
all
of
of them,
us.
the complication. But I read in the comment
Mm-hmm.
one doctor mentioned gynecological as a cause.
Yeah.
I don't
Mhm.
think it can be unless there is injury to the bowel. They can do the ileostomy. Okay, if the injury or iatrogenic injury to the bowel, you might have the ileostomy, but it's not as a cause of ileostomy in general.
Yeah.
Clear?
Yeah. Any known question in this topic that I didn't cover?
No, no,
Like
no.
any
It's
frequently asked question?
you cover all of them, but they ask one more question. What are the
Mhm.
differential of right iliac fossa mass and left iliac fossa mass?
Okay.
Sometimes they are asking, and we end this topic with this question. Dr. Salma, what are the cause of left and right iliac fossa mass?
Right iliac fossa mass. Maybe cancer, colon cancer. Maybe appendicular mass. Maybe polycystic kidney disease, and maybe ovarian mass. If lady.
Yeah, you can say that, but how come you can say polycystic kidney? Is it in the right iliac? Or you want to say transplanted kidney?
Transplanted kidney. But this
Yeah.
is polycystic transplanted kidney more accurate. But polycystic kidney will not be. We need if it is very big, will not be palpable. No,
It's
sir.
palatable at the flank.
At the
At
flank,
the flank.
not in the iliac fossa.
Yeah, and
Hmm?
did you mention the TB and
No,
appendicular
I didn't mention.
mass? Appendicular mass as well?
Can.
Yes.
Yes, can cause. Can cause.
Yeah. And the other
Yeah.
side as well will be the same, but you can say that the organs will be involved there. The
Yes,
colonic.
in the left side, mostly can
Mm.
be also colon cancer, can be diverticulitis also,
Yes,
can be
perfect.
like in the left side, can be ovarian cyst,
Yeah,
can
in the
be
female. Exactly.
yeah, can be hernia, can be swelling lymph node.
Okay. Thank you, Dr. Salma. I think now we can end this case. We can move to the next scenario.
Yeah.
I will
Can I,
read the
can you
comment.
give
Yes.
me just 1 minute? Just 1 minute. I'm just going to check the door. 1 minute.
No worry. Dr. Samira add ulcerative Crohn's, familial adenomatosis, polyposis, adenomatous polyposis, colorectal cancer, trauma, gynecological cause. Okay. As I said, it's not commonly be associated, the gynecological, unless there is injury. So you have to mention trauma or iatrogenic trauma to the bowels. Usually they do it. We have a real case in the practice. After they do hysterectomy, they have injured the bowel and they did the ileostomy. So you're right, but you have to mention if there is complication or injury, iatrogenic injury to the bowel. Dr. Samira, again, digital stoma exam for stoma stenosis, stoma obstruction, stoma prolapse, necrosis. This is what you should do also whenever you have ileostomy or colostomy bag. Don't only observe from outside. You can offer even examining, but of course with gloves. Okay. Whenever you have it in the exam, you can offer by using gloves. Can I examine inside? And you can touch the wall, check for the redness, check for inflammation. Of course, again after the approval or permission from the examiner and using gloves. Yeah, by carb losing, so it will be metabolic acidosis. Perfect. Any question before moving to the next scenario? Dr. Salma, you can share the scenario already?
Okay, it's
Yeah.
very near or maybe same to your scenario, but I take it from different view, different diagnosis.
It's okay.
Okay,
Before,
I will leave same
okay,
photo. You
okay,
give me ileostomy back. Leave this photo. Same I prepare. Then I will pass now.
okay. Send me the photos. Anyone want to comment before moving to the next scenario?
For Crohn's disease, is it common to do ileostomy in Crohn's? You said, Dr. Bassem.
Whenever you have a complication,
Mm-hmm.
so you can do it. Like as I said, obstruction or fistula or recurrent sores or flare up, toxic megacolon. So if there is complication, you might have ileostomy for
Mm-hmm.
it, just to resolve the inflammation. Or if you have mass complicating. So all of them can be done. But the other indication, as you said, the ulcerative colitis, whenever you have total or subtotal colectomy, you might do it.
Yeah,
So it
but
depends in the area of inflammation and the flare up.
yeah.
Yeah,
But did we all get that like sun-shaped scar on the right iliac fossa? If everyone see it, this is a temporary mucus fistula, representing a temporary mucus fistula,
yeah.
which
You have
will
to know the difference, as you said, and Dr.
which
Salma already mentioned,
mhm,
what the difference between the colostomy and the ileostomy.
yeah.
Yeah,
So the presence of this scar is suggestive of that the operation that the ileostomy she had it under emergency setting.
Whenever you have what again? Sorry.
This is the left iliac fossa scar, this sun-shaped scar that we are seeing. This is representing a temporary mucus fistula that's been done and it's been closed. And they usually do it under emergency setting.
And it can be permanent as well. It's not only temporary.
No. That I'm not talking about the stoma. I'm talking about the ileostomy. I'm talking about the other scar.
The nearby scar, you mean?
Yeah, the scar in the
Okay, yeah,
left
yeah.
iliac
Okay,
fossa.
yeah, yeah, yeah.
So in that video, what they have suggested is that this represents a temporary. I've written it here, a temporary mucus fistula, and likely it's suggestive of emergency management of the bowel. So she has presented once with a flare that didn't respond to the medical treatment, therefore it required the surgical management, which means that it wasn't a planned surgery or a planned ileostomy.
Okay, I didn't get it clearly, but it's okay. If you saw this video, you mean?
Yeah,
Okay. So if you have two scars, means that there is emergency to do this
yeah, and
ileostomy.
the other scar is called temporary mucus fistula scar. That has significant suture marks around it, making like a sun-shaped, or if you can zoom, you can uh, uh, see it. So um, what they have explained
Okay.
that this is
From where
suggestive
this
of.
video? You mean
It's in
from
past test.
past
In
test?
past
Okay,
test,
you
yeah.
can share the video. You have it offline?
Uh, no, I
Right.
couldn't find it
Okay.
offline. I'll try to find it.
Yeah, it's better to be having it. We can know the rationale of the other. It's like colostomy or mucus stoma. You mean mucus stoma?
Mucus fistula.
Mucus fistula. Okay.
Yeah, it is a temporary stoma. So she had temporary stoma on the left iliac fossa, and they phrase it as temporary mucus fistula. And then they've taken out the stoma, and this was connecting to the rectal stump, the
Yeah,
other
yeah,
the
yeah.
other
I
one.
got it. Yeah,
Yeah,
yeah, yeah, yeah. Yeah, for the terminal end. Yes, yes, you're right.
yeah,
Yeah. So they can drain the secretions from the large colon.
yes, yes.
Okay. Yeah, I
So
got it. Yes,
and
yes.
this was just of that this procedure has been done
Yes,
under
yes, yes.
emergency setting.
Yeah, 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 yeah. You're right. Yeah. I got it now. Yes. Okay. Okay. Any other comment you want to add before starting?
No.
Okay. Dr. Dua added appendicular mass versus abscess, ileocecal tuberculosis, carcinoma of the cecum, ovarian cyst, Crohn's disease, but can also involve the abdominal wall, lipoma, abscess, retroperitoneal, psoas abscess, sarcoma, and undescended testis, aneurysm. Okay, all of them are, yeah, you can mention, but you have to say the common list, then the less common. Okay, we can start now, Dr. Omar, ready?
Yeah.
Mr. David, 35 years old, present with large weakness, examine the lower limb. I will share the photo while starting the discussion. Here you go.
Okay. Hi, hello. My name is Omar. I'm one of the doctors. Are you Mr. David?
Yes,
Yeah. Thank you, Mr. David. I've been asked to examine your legs, because you had a problem with them, or some weakness. Is that okay for me to start with?
yes. Okay.
I'll look for the surrounding if the patient is in a wheelchair, or if there's any orthotics, any uh, other or walking aid that would be
Yes,
suggestive that
there
the
is
patient
walking
is
aid.
something. Walking aid.
Yes, there is. Yes,
Mhm. Are you able to walk, Mr. David?
with difficulty.
So it's difficult for me to ask you to walk. No problem.
I can walk, but it's
Okay.
very difficult. Yes.
Okay. So I'll shall I Is it difficult? You can't walk, Mr. David? Can I
Yes, I
see
can
you?
walk.
Okay. I would like to examine your gait, please.
Okay. White ataxic gait.
Ataxic gait, broad. Okay.
Yes, wide
Um,
ataxic gait.
so I wouldn't be doing tandem walking. Do Rumberg
Yes,
against the bed.
Romberg test.
Note trying to note if he's looking to his feet when he's making his feet close to each other's. Um, and then to ask him to close his eyes and then to look if there's any sway.
Yes, positive.
Positive Romberg test.
Yes,
Okay.
yes.
Then I'll thank you, Mr. David. You can lay down in the bed. I'll ask you to roll up your sleeve up and uncover till the upper part of your thighs. Is that all right?
Okay.
I'll inspect the leg for any visible fasciculations, any visible scars, any muscle wasting either proximally or distally.
Normal.
No muscle wasting, no muscle hypertrophy.
No, no.
Okay, okay. Now I'll test for the tone quickly on both legs to shake. Then I'll do clonus.
Yes, there is hypertonia.
Hypertonia bilaterally or
Yes,
on one side. Okay.
yes.
And clonus negative.
Upgoing.
Clonus.
Colonus
I
positive.
will. Clonus is positive. Okay.
Yes.
And I'll start by testing the power in the thighs with or without hypertonia, with or without, first without resistance and then with resistance if he's able to.
Okay. For power. Okay. Uh,
In the thighs,
uh, yes, I can raise leg.
both legs. So with resistance now, and I'll ask him to push my hand against the bed.
Yes. Weak.
So weak,
There is weakness. Yes.
proximal. Okay. And I'll ask him
But
to bend. I'm sorry,
yes,
Dr.
you
Salma, there is, I don't know, just one second. There is some noise.
yes, sorry.
Can you hear me?
Yes, yes, I can hear you. Yes.
Okay.
Uh yes. When examined, or you find flexor is weaker than extensor, and you find also um, abductor is weaker than adductor, and distally is more weaker than proximal.
So distally is more weaker than proximal.
Yes.
I'll now go and so he can't basically uh, roll back his ankles and his ankles are weaker. Uh, I mean that his foot, his both feet is weaker than the thighs.
Yes.
Yes. Okay. Thank you. Um, then I'll test for the reflexes,
Okay.
knee and ankle and
Reflexes for
plantar.
okay for knee hyperreflexia. For ankle absent ankle reflex.
Ankle is absent. Now I'll and blunters,
Upgoing.
upgoing blunter, and then I move to coordination if he's able to. Heel to shin test.
You want me to do heel shin test intact?
Intact.
I
Okay.
can do, yes.
Okay, and then I'll start assessing the sensation, pain, sensation down till the
One
toe,
minute
and then
left.
upgoing, and then
Okay.
it is for glove stocking.
For sensation, impair vibration sense.
Okay,
Impair vibration sense up to the ankle.
up to the ankle. Okay,
Yes. Yes.
so pain touch sensation is intact. Vibration
Yes,
sensation is impaired. Joint positioning.
yes.
I'm sorry.
Intact.
This is another photo that's been shared. Is it related to this case?
Yes. Is it, you know your picture ileostomy back,
Mm-hmm.
ileostomy back, and stick and clubbing. All this is a picture for the same patient. You can check the
Mm.
book.
Okay. 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 No problem. Um,
Yes.
Now, yeah, we've completed the sensation. I've completed my examination. Thank you.
Thank you.
Okay, collect your thoughts, then examiner will start.
Okay.
Okay. Can you present your case?
Today I've examined Mr. David, who has presented with weakness in his legs. From my examination, I found his finding is consistent with uh, 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 bilateral spastic paraparesis with uh, absent ankle reflex. There was no sensory involvement apart from the vibration sensation. Um, and this gentleman does have evident clubbing by looking to his hand from the bedside. And he had also, I noted a colostomy bag. Putting all of this together, I think this gentleman might be having subacute combined degeneration of the cord, given that he had ataxic gait. Romberg was positive and
Yes.
tone was increased bilaterally. Ref, and brisk knee, absent ankle, upgoing blunter, and the vibration sensation was affected. This would represent involvement of the posterior column of the cord.
Okay. What your differential?
My main differential, I would say that likely it will be malnutrition, uh, possibly, or second, which has led to vitamin B12 deficiency, which has affected the spinal cord. So I'm thinking of subacute degeneration of the cord.
Okay, I mean other differential for the same
Other
for this case.
differentials. Um,
Yes. Not the causes.
um, Motor neuron disease, but again, is that this should be
Yes,
a
good.
fasciculation.
Yes.
Uh, this gentleman is young, um, Friedrich's ataxia, but he will have absent ankle, absent knee reflexes. Um, if this symptom is acute, then we can think of trauma and uh, cervical disc prolapse, cervical myelopathy, and
Okay.
um,
Okay. Okay.
uh,
What do you think the cause of subacute combined degeneration of the core in this case?
uh, likely short bowel syndrome, which may has led to um, bacterial overgrowth, for example, which will decrease the absorption of the vitamin B12, as the site of the absorption of vitamin B12 is usually from the terminal ileum. Given
Yes.
that my gentleman is having an ileostomy, then the site is affected. He might not be
Okay.
taking the supplementation as usual.
Yes. Yes.
So a thorough history, taking a look to medication list
Okay.
is
Good.
wise.
Can you mention other causes can be for other cause of
Vitamin
uh,
B12 deficiency.
B12 deficiency? Yes.
Alcohol, alcohol is one of the most common causes in UK that's associated with vitamin B12 deficiency. Um, um, uh, Malnourishment in general, decreased oral intake for any reason. Yeah.
Okay, can be pernicious anemia.
It can be pernicious anemia,
Yes, yes,
but
can be also as general.
it would be suspected if there is other autoimmune
Yes, this is as
problems.
general. This as general. Yes, yes,
Mhm.
yes.
Yeah.
Okay. How will you investigate?
I'll start investigating specific investigation. I'll sample blood count, looking for any macrocytic anemia, nutritional bloods, including vitamin B1, 6, 12, and to test for intrinsic factor, and to send to do a breath test to test for uh, SPBO, which is subacute um, the bacterial overgrowth, basically, and the general bedside investigations, including ECG, chest X-ray, and lying and standing blood pressure, urinary depth, checking for blood glucose. Um, yes,
Okay. Vitamin B12 level, you do it already? You want to do folate level
I
also?
yeah, the nutritional blood vitamin B1, B6, B12, and folate. Yeah,
Yes. MRI of the spine also can be mentioned. Okay. Okay.
yeah.
How we will make?
How how I will manage. Okay.
Yeah.
Multidisciplinary approach. This gentleman needs to be reviewed by gastroenterology and dietitian, as well as a neurologist, to review the images of the MRI, and then physio and occupational therapist to help, um, which I will start. I think it's wise to be started as an inpatient if there is no injury to the spinal cord would prevent their early input, to help regaining the function of the legs back, um, to identify. We need to look for the reason why the vitamin B12 is not being given, or if it's given, um, um, to look for potential losses. If the bowel overgrowth, small bowel bacteria overgrowth is suspected, then antibiotic management or treatment should be, of course, loading the patient with vitamin B12 as an
You mean
inpatient
to read the
to
cause,
start with.
to read the causes.
Yeah,
Yes.
yeah.
Vitamin B12. Yes.
And then to load the patient with vitamin B12 while it's in hospital.
Okay. 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 Thank you. If there is time, I can ask one question.
Yeah,
Yeah.
the last question, okay?
Okay. Is there any vitamin deficiency that can mimic vitamin B12 deficiency by
Uh,
making same picture?
vitamin thiamine, but it would involve more
Vitamin deficiency can cause same picture
folic acid.
of B12 deficiency. Yes. Okay.
Folic acid, yeah.
Other, yes, folic acid and vitamin, other vitamin,
Vitamin B6 and B1, the B complex.
Yeah, no, vitamin E. Vitamin E can
Vitamin
make
E.
picture same too. Yes,
Okay.
can make picture same thing. Okay, thank
Okay.
you very much. Good job. Thank you.
Thank you, Dr.
Great.
Salma.
Thank you.
I didn't feel that I did a
Okay,
great job.
okay, thank you, Dr. Salma, for the questions. Dr. Omar also, he did perfect, really. You can comment now based on the skills.
Uh, I يعني is doing good, but I noticed that only when examined heel for heel shin test for coordination is forget one point that uh, should do it again and tell me close your eye and do it again
Hmm.
because maybe there is sensory ataxia as this patient have sensory ataxia. Yeah,
Yeah.
يعني do it open eye and close eye for heel shin test.
Yeah, I didn't do it because the Romberg was no, no, yeah, you are right. Romberg was
Yes.
positive. Yeah. But
Yes,
Romberg was
this is
positive,
the
yes.
only point I noticed. Yes, this is the only
So
point I
there is
noticed.
consensus behind the
Otherwise,
meeting.
it's all good. Yes.
Yeah.
Dr. Basim, if you have any comment.
The other skills was well maintained.
Yes, differential diagnosis good. Is mentioned three. It's a good differential. Examination also good. Um, uh, I think all is good. All is this point I mentioned in examination. Otherwise, I feel everything is okay. If anyone other want to comment also, it's okay.
So I didn't mention the MRI until I prompted, so I think I should be
Yes,
minus
in
for this.
investigation, MRI is important. Didn't mention also. Yes,
Hmm.
yes. Then
MRI both head, brain, and MRI spine.
So you
yes,
can
for
minus
spine
him.
is very
You want to
important.
minus only in the clinical judgment, or it's okay. You can give him the all. Anyway, the question
I
will not
give
take
this
this long.
Dr. Basim
However,
also.
yeah, as I always say, don't give the option of investigation to the blood workup only. Also, not bedside only. You have to mention all of them to give a chance to the examiner to ask you which category he wants you to mention. Is it imaging? Is it bedside? Is it specific? Is it general? Is it invasive? All of them can you can have one or two tools to do to diagnose your case. As we said in the MRI, the imaging can help to diagnose the subacute combined degeneration. For the bedside, he mentioned all of them: the ECG, echo, and the nerve conduction study, neurophysiological study. Also, he can add regarding the specific, the vitamin he should mention. I think he mentioned it, right? The vitamin screening, as well as the folic acid.
Yeah, I
Yes,
What?
this
mentioned,
is
but I
very
didn't
important.
mention vitamin E. I
Okay,
didn't mention
I
vitamin
will
E.
ask you more advanced question. What do you think the blood picture will be?
So it will be macrocytic anemia
Yeah,
as
perfect.
It will be hypersegmented neutrophil in peripheral blood.
Yeah, this
and
is
smear.
Hypersegmented.
blood
Yes,
smear. Yeah, I'm
Mm.
asking
yes.
about the CBC, differential CBC. What you
Yeah,
could.
so it will be
Macro,
macrocytic
yes.
anemia with
Is
one
it macro only, or you can give another term?
megaloblastic.
Megalo,
Yes.
okay.
But the
Yeah.
blasts, yeah, the blast should, if you found if there is megaloblastic, I think the blast would be after the film. Uh, but anyway, in the exam, the one who is examining you doesn't have that deep hematological knowledge.
Yeah, yeah, but megaloblastic, macrocytic, both of them can fit the case.
Mhm.
Okay, so you can mention both, but megaloblastic more specific. The other question I would like to add also the management. Yeah, what you can correct first? What prefer to correct first? Is it
Oh,
folic
B12,
acid or B12?
B12, B12.
Yes, always remember the letter is coming before F.
Yeah,
Never ever correct the folate deficiency before the before the vitamin B12. You might exaggerate the condition. Okay.
but Dr. Bassem, when I gave the differential, did I overshoot in the differential, like when I added, or did I mention sensible differential?
I think what you give as a vitamin B12 deficiency related to the absorption areas makes sense.
Yeah,
But related to the clubbing, do you think it can fit all of you, your differential?
the clubbing
Clubbing is only
can
Yes,
represent
Crohn's.
the cause of the
Yes, related
colostomy.
to. Yes.
exactly. So, but malabsorption will happen with other condition without clubbing.
Yeah,
The clubbing only associated with the inflammatory bowel disease.
yeah,
Yeah. If there is celiac, you can say that celiac can be with the same manifestation, right? Celiac disease
yeah.
because of malabsorption as well,
Hmm.
and short bowel for other reason than Crohn's. You can
I
mention it.
Yeah, I thought it could be due to
Bacterial.
short bowel,
Yeah.
but it didn't. Yeah.
Yeah, and you mentioned the short bowel and the irritable, bacterial overgrowth, right?
Yeah, yeah.
Yeah, but
And the folic acid in both will be very high on the
according
bloods.
to the area of remove
Yeah.
of
Yeah,
resection.
terminal ileum mostly will be side of
No,
the
no.
absorption.
For the folic acid, there will be a discrepancy always between folic acid and vitamin B12. You would find either normal or elevated folic acid if the cause is bacterial overgrowth, because the colonized bacteria is producing more folic acid and consuming all of the vitamin B12 in the gut.
Yeah, but if you want to
Uh,
say also short bowel, you have to mention the area of the resection.
yeah, I mentioned the
Yeah,
terminal
as
ileum.
Dr. Yeah, terminal ileum. Yes, yes. This is another point. One more point I want to put here or to add regarding the complication. Yeah, I think the differential you can put in the top of your differential inflammatory bowel disease in the top of my differential. Then I can say malabsorption because of other condition, because I have clubbing in this scenario. Other condition doesn't have the clubbing. As I mentioned, the celiac not usually associated with clubbing, right?
Yes.
So in the top, I will say in the view of the clubbing and the colostomy or ileostomy and the malabsorption. So in the top of my differential, I put inflammatory bowel disease associated with malabsorption diarrhea, then causing or leading to the vitamin B12 deficiency and subacute combined degeneration. Then you can add other cause, as I said, but the most important to mention in the top will be inflammatory bowel disease. Okay.
Hmm. But should I start by mentioning the differential diagnosis for the weakness? Or n- no?
Because they added a manifestation here or a
Yeah.
sign, which is ileostomy and clubbing, you are
Mm,
restricted to mention the cause related to the vitamin B12, subacute combined degeneration. If you
mhm,
don't
Yeah.
have these signs, you can put the weakness and the sensation of fiction differential. So you can put the multiple sclerosis, right,
mhm,
as a features of upper motor neuron lesion.
mhm,
Motor neuron, so it will be multiple sclerosis, subacute combined degeneration, tabes dorsalis, right? All of them can
mhm.
cause dorsal column affection, and they have the pyramidal weakness or features of weakness, right?
Yeah.
Dr. Bas?
Dr. Basim,
Yeah.
Okay.
sorry.
Okay, go ahead, go ahead. Dr. Basim, I was thinking, like Dr. Omar said, motor neuron disease. Like, I think we will be going very off the tangent if we start with motor neuron disease here. Like, it doesn't fit in our scenario.
Yeah,
Like,
if you
yeah,
yeah, if you see, I didn't mention motor neuron in the differential.
yes, yeah. And like Dr. Omar
You
pointed
mention
out,
it?
I
yeah,
mentioned it, but I said again is that there is no fasciculation and there is a brisk ankle absent knee. In
uh,
when I asked what other differentials you can offer. So
But also, I don't think the motor neuron can fit because all sensation will be normal in motor
yeah.
neuron.
Yeah, and maybe conus
But
medullaris we can put because the dorsal column is involved and it looks like subacute. Like if we want to put anything related to the spine, then conus medullaris goes towards the same kind of differential
as
rather
upper
than
motor, yeah.
yes, rather than motor neuron disease.
But also, if you want to say the multiple sclerosis will be more proprietary
More,
to,
yeah, more,
yeah,
more.
yeah,
transverse myelitis causes in general. Yeah.
transverse myelitis
The
and
sign,
also tabes
the
dorsalis, so dorsal column affection.
the sensory level will be there in transverse myelitis.
Yeah, supposed to have a sensory level in the
Yeah,
transverse myelitis, yes.
Yes.
yeah.
But multiple sclerosis, I think, yeah, it would be as a second differential. Again, in the view of the other signs, you can ask the examiner, you want me to give differential based on the manifestation of vitamin deficiency or the weakness and the neurological manifestation that the patient is having.
Yes.
So,
Also,
yeah,
look, there is differential for absent ankle reflex,
Yeah, there is a lot of
upgoing
different.
plantar.
Yeah, so
Yes,
this is
upgoing
what
plantar.
this is the differential that jumped into my mind. Okay, I do have
Yes,
brisk knee, absent ankle. So
yes,
two main differential, subacute and MND, but against that MND, against MND, there is
yes.
sensory involvement and there is no fasciculation. So, and then I give differential from the rest of the list.
True. In a book I read about this case, is mentioned motor neuron disease as a differential, and again is that there is motor neuron disease, no sensory loss is mentioned like this point. But I want to ask, syringomyelia can be a differential here or no?
Yes,
Uh,
syringomyelia as a manifestation also of upper motor with some sensation affection, but
yes.
usually I think it's not the dorsal column, right?
Yes, yes,
There is no
membrane. Huh?
dorsal column. Yeah, there is
Yes.
usually in the beginning there is no dorsal column, but
Yeah,
you
but in
can
the
say I
advanced
would like to
case, yeah.
confirm in the upper limb if the same sign are present, and that's it.
Yeah, you might have the manifestation in the upper limb in the form of pain and temperature sensation, loss of sensation. But again, it can be there. It can be one of the differential with as you said the ankle loss of ankle reflex
So
or
loss of yeah.
mixed upper and lower. You might put it syringomyelia and also you can say cervical myelopathy.
Mhm,
But I think they will not ask about the neurological compared to the question for the manifestation of weakness related to the vitamin B12 deficiency, since this patient is having the colostomy. And definitely they have to show you the colostomy or the ileostomy bag. I don't know if they can give you a hint there is a clubbing, because once we shared it, you notice it. But if you couldn't see them, I don't think they can.
because in the neuro case, usually it will be odd to ask the patient to take off his shirt,
Yeah,
unless
unless
you
they
walk
are
them.
asking
Yeah.
him to do so.
Yeah. Um, I don't know what hint could be there if the patient would be like wearing short only with his and he's not wearing his shirt for the examination purpose, because you usually enter the room very quickly and the patient
Yes.
is usually sit for the exam. You don't need to ask him to do so.
Mhm.
I don't know.
I'm not sure they can tell you just look at his abdomen, or maybe at the end during the discussion they will tell you there is a colostomy in this patient bag, or there is a colostomy bag or ileostomy bag in this patient abdomen.
Mm,
So now what you think about the causes, and they can deviate the discussion toward the subacute combined degeneration.
mhm,
So they can direct you to the other topic and might ask about other differential related to the weakness, but also they want also to hear the manifestation or the differential of the subacute combined degeneration, in particular the dorsal column affection. Okay, so it depends on the exam, the center. I'm not sure if they brought a case like this before, but it's a good case to mention and to discuss today as subacute combined degeneration related to malabsorption.
mhm.
Any other question, Dr. Salma, or comment?
Thank you.
Let- Yeah, I will read quickly the comments. Syphilis, tabes dorsalis, Dr. Aisha, yes, we mentioned it. Dr. Samira, the last comment. I think the best to ask examiner about the differential. Is it for B12 differential or for spastic paraparesis or brisk knee with absent ankle? I agree about this comment. Totally agree. You might start answering differential, which is not the examiner need. So please, if you feel the examiner is not satisfied with your answer, you can repeat his, or you can ask him, doctor, you want me, or say you want me to give you differential for the manifestation, for the weakness, for the dorsal column. Show him that you are aware about the differential, but if you give me the clue what you want, otherwise you might go enumerating your differential, and at the end he's not listening to you because he want to hear something that you didn't mention at all. Thank you, Dr. Samina. It's a really good comment. Motor neuron disease. Yeah, we discuss about this point. No term of megaloblast and peripheral blood film. Yes, Dr. Ihda, we are saying in the CBC differential, not in the blood film, or sorry, the blood smear or blood film.
السلام
Yes.
عليكم.
Walaikum assalam. Yes. Tell
Uh,
us as a hematologist what you want to say.
regarding peripheral blood, same name of peripheral blood equal to CBC equal to peripheral hemogram, all the same name. Okay. Regarding megaloblastic anemia, RBCs either macrocyte or evaluomacrocyte, and the characteristic of evaluomacrocyte, because many causes for macrocytosis, reticulocytosis, hypothyroidism, liver disease, like this. Okay, so the problem in RBCs, macro ovelocyte, but megaloblast, the term of the disease itself referred to bone marrow finding. Megaloblast means there is a dissociation between maturation of cytoplasm and nucleus maturation, asynchrony between nucleocytoplasmic dissociation, because defect of DNA hindering or prevent nucleus maturation, but the cytoplasm become mature. So the cell mature in cytoplasm, but immature in nucleus. Any cell immature in nucleus called blast. So that name of macroblast.
And it's always in the bone marrow, you want to say, not in the blood film.
Yes. Yes.
Oh. So the term megaloblastic, you cannot tell it based on the
Unless you have a
CBC.
bone marrow. Yes, unless you have a bone marrow
Yes, perfect.
examination.
Yeah, that's a good point from hematology. Thank you. As a hematology point of view, Dr. Hida is a hematologist. So she gave us how and why we are saying macrocytic anemia. Don't say megaloblastic unless you have the bone marrow as confirming or the confirmatory test, right, Dr. Hida? This is in summary.
Yes, Dr. Bess.
Okay, thank you so much. Thank you. Go back to the comments. Yeah, Dr. Dua, differential subacute B12, folic acid, copper deficiency, vitamin E deficiency, HIV, vascular myelopathy. Alcohol as well can cause. Okay, don't forget the alcohol. Along with these, you mentioned pernicious anemia, Dr. Strict vegetarian drug, metformin, PPI, gastric, bariatric surgery, Helicobacter pylori, atrophic gastritis, terminal ileal disease as lymphoma, TB, Crohn's. Perfect. Dr. Tahani, anti-intrinsic factor antibody and parietal cell antibody as investigation, you want to say, for pernicious anemia, yes. Again, pernicious anemia can be as a differential of vitamin B12 deficiency without clubbing.
Yeah.
Copper vitamin. Okay. Yes.
One more thing about the test for the SBBO is the carbohydrate breath test. So
I don't think it's anymore doing
because I
this
forgot
test.
it. Or a hydrogen breath test?
Yeah, they
Yeah.
are still doing this test.
I don't know, but this is what I forgot to say in my investigations. So I don't know how they test now for SBBO because this patient does have a bowel resection, so short bowel can
Yeah,
be
hydrogen
suspected.
breath test. Yes, it's
Yeah.
there. Yes, you're right.
Yeah.
Yeah, you're right. You have to mention it if you suspect it. Yes. Okay. Thank you, Dr. Ama and Dr. Salma. Any other comments or question? It's brain
I will add
storage.
Dr. Basim,
Yeah, Dr.
Dr.
Mahjoub.
Omar.
Yes.
Dr. Omar, just simple advice. If you become systematic, even in how to examine and how to introduce, you will not forget something. Yani, I mean, if you in the case of neurology, if you start by inspection, tone, power, reflex, then you want to coordination, and the last one to get, it will be better. You will not miss something in the presentation and also in the examination, because you start from the gate and then you went through, and then when you start to introduce, you start the general rule, then you start to collect the what is going the symbol finding. If I think like this, maybe you will expose yourself, maybe you will miss finding or something like that. But if it keep it simple like this, as you examine, then you will present your finding. It will be you will memorize everything. Inspection, tone, power, reflex, coordination, then gate. Then you will present the same sequence. So I think by this way you will not forget something. And in this case, you did great, by the way. But to me, just the clinical judgment, because this is
Mhm.
considered peripheral neuropathy, you need to, and also weakness. They already mentioned the nerve conduction study, MRI. This is in the investigation, and in background of this pictures, the patient with inflammatory bowel disease. Also, you can put the malabsorption also at the top beside the bacterial overgrowth, as you mentioned, because يعني maybe they put these pictures at the background to mention why the causes underlying, يعني why the underlying causes of B12 deficiency in this situation. But otherwise, you did great.
Thank you, Dr. Mahjoub. If you want to present this case, can you just for me to learn, can you give an example of representing this case? Um, um, Hello, can you hear
Yes,
me?
yes, yes. I hear some one of them. They said there is two methods. Either you will say the as you examine. For example, I examined this spine. I found, for example, there is a walking aid. Beside this, the tone there is hypertonia, the power or there is weakness, the shape of weakness like this. For example, pyramidal or non-pyramidal, the
Mm-hmm.
sensation. Yani, this is number one. You will
Mm-hmm.
you will do like this. Then at the end you will say, for example, this there is like uh, peripheral features of, for example, in this case, peripheral neuropathy. Then you will see the underlying causes of this, or you will give another pictures, like you will give like a diagnosis. This patient like paraplegia. This patient had bilateral paraparesis or paraplegia according to. Yani, I mean, you will give the sum, then you will go to the details, or you will give the details first as you examine from the start. Then you will give your hint.
Mm-hmm.
Dr.
Thank you, Dr.
Mahjoub,
Mahjoub.
I will comment on this. Some doctors prefer to start with the gates. Usually, the gates have a lot of clues. It can give you guide you to this. That's why Dr. Omar, I think he's starting with the
Yeah.
gates. It's okay to start with it, but during the examination as a neurological, the steps of tone, power, reflex, as Dr. Mahjoub, I prefer to do it in this way: tone, power, reflex, coordination, sensation, and even when they present, you present in the same way: tone, power, reflex, coordination, sensation. The gate, if you want to say at the end, it's okay. If you want to say at the beginning, it's okay. But if you want to start the examination by examining the gate to know what the case about, it's okay. But mention the gate after the saying the feature that you have. So you are saying the feature is suggestive, upper or lower or mixed upper and lower motor neuron lesion in the form of 1, 2, 3, 4. The sensation is impaired in the form of the superficial or deep, whatever. Then the gate here is and describe the gate. In this way, you can get full mark in the clinical in the presentation as the physical finding or physical examination, identify the finding and the clinical judgment. They like to hear in this way. But the examination steps, if you want to start the gate, it's okay. If you want to make it at the end, it's okay also. Okay.
Okay. Can I do have one question about presentation, especially in neuro, because when I gave the exam, there's some examiners would let you to say whatever you would like to say, and some examiners would now interrupt you. Okay, what's your diagnosis? So, or what's your positive finding? Don't say blah blah blah. This is their way. So I've encountered both types of examiners. So in this case, what's your advice, or if anyone does have an advice to help how you should recap.
You know,
If
whenever
I choose to start like, today I've
yeah,
examined
I will
gentlemen.
tell you. I will tell you. Whenever you are mentioning upper or lower motor neuron lesion in the beginning of your presentation, it will show the examiner that you summarize all the presentation in one word. Then describe what you have seen in both or all the manifestation of upper or lower.
Mm-hmm.
So, but don't give a diagnosis. You are not neurologist. You don't have the tools. You don't have the investigation to say this is, for example, multiple sclerosis. How you could say it without history? So you can say I find a feature suggestive of upper motor neuron lesion in the form of hypertonia, hyperreflexia, positive clonus. The power is impaired in the pyramidal, distal, or proximal according to the distribution as you see. And the sensation here was impaired or not impaired according also the case. The gait is spastic, for example, in the multiple sclerosis. In this way, within or less than 1 minute. They don't like to talk a lot, expanding the presentation more than 1 minute. Okay, they will stop you. Doctor, tell me what is the investigation you want to say.
Mm-hmm.
You got it?
Yeah.
Yeah. So this is the way how to do. The first word should be or supposed to be either upper or lower motor neuron lesion. So you summarize the all finding in one word with the like to hear.
Mm-hmm.
Yeah, that's it. But you do have the way to present. You are perfect, really. You do it perfect at the step of examination and the presentation and the discussion, the fluency. All of them, you have good talent to pass this station. In particular, the neurology. You have good knowledge. But give the examiner always the time or the chance to ask.
Mm-hmm.
Okay. Any other question?
Not from my side. Thank you, Dr. Bass.
Oh, okay. Thank you, Dr. Omar. Okay. Anyone with other question or comment? Clear for all. Thank you, Dr. Omar and Dr. Salma. Thank you, everyone, for the attendance today. See you tomorrow, inshallah, with the non-clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thanks, Dr. Salma. Thanks, Dr. Bassam.
جزاك الله خير.